So this is a session after a full lunch, after a full morning of workshops. So I understand that folks may be a little tired. So we're going to try to energize you with the really helpful and innovative and interesting content that we have for this workshop today. So we're going to kick it off. Can I just ask everyone to stop talking to each other? Okay, and give your attention to our wonderful set of speakers. So let me get started. My name is Helene Lauffer. I'm the Chief Operating Officer at the Jewish Board. And I'm just going to take a minute as moderator of this conference before we really kick off to tell you a little bit about the Jewish Board and why I was asked to moderate. So the Jewish Board is a large behavioral health and human services agency. We have a similarly large portfolio to the Bridge, which is presenting this workshop. And in addition, we have a similarly large supportive housing portfolio. In addition, we run 14 mental health clinics. We run a number of ACT teams, PROS programs, care coordination. We have child residential programs. We have domestic violence shelters. We run foster care prevention, and we run residential programs for people with intellectual and developmental disabilities. So kind of a broad range of services. But there's a special reason that the Jewish Board was invited to introduce this workshop, which is that we've developed a partnership with the Bridge to share program knowledge, strategies, and documentation in two areas in which our respective agencies have developed expertise. So the Bridge has been an innovator in working with the growing population in support of the growing senior population in supportive housing and helping them age in place to the extent possible. And a foundation funder who supported the Bridge's work encouraged the Jewish Board to work closely with the Bridge, and that developed into a partnership. So at the same time, the Jewish Board has developed innovative programming to address hoarding, excessive clutter, and excessive grease and grime among people who live in Jewish Board supportive housing. And we offered a workshop about that, I think, last year here at this conference. So the Bridge was interested in learning the approach we're taking and developing their work in that area. And we believe that this partnership between sister agencies is a wonderful model that is generally underutilized in our field. And the Jewish Board is really fully invested in this partnership and, hoping to continue to develop it. So lastly, I wanted to also state that the Jewish Board is stepping up our own agency's game in terms of high-risk management in supportive housing, which is the topic of this workshop. And we have weekly high-risk meetings at the housing program level and regular divisional high-risk meetings as well. We are more actively pulling in our chief of psychiatry, and we have a chief medical officer and a chief nursing officer, and we're really working now to integrate them into these high-risk meetings when we need consultation and intervention. When we have a really serious incident now at the Jewish Board, we do a same-day or next-day huddle, bringing in compliance, medical, psychiatry, and program, obviously, so that we're all talking about what happened, what still needs to happen, how to support the program following a difficult incident. And we're piloting risk reduction strategies such as selectively or strategically utilizing security personnel during certain home visits or certain client interactions. And we've recently created a new director of security position at the Jewish Board. So we're really keen to hear about how the bridge is approaching risk reduction and supportive housing. And so now we're going to roll forward with that part of the presentation. We're going to try to keep questions till the end of the presentation, and we look forward to engaging with you after that. But let's start with introductions.
Hello. Oh, good. It's on. Hi, I'm Lexa. I'm the Director of Clinical Risk Management. A little bit of background about me is that I graduated from Hunter College. I know some of my fellow colleagues are in the audience. Hi, I miss you all. I then, during my MSW, I was an intern at the Bridge under the Aging Services program before going over to the ACT team for about 3.5 years and working as a wellness specialist. And I learned a lot on the ACT team and then was able to come back to residential to start building this program in 2021. I started as the clinical coordinator and last year became the director of the program because we hired some more staff. So I'm going to pass it on to Surgein now.
Hello, can everyone hear me? My name is Surgein. I'm the clinical coordinator for the clinical risk management team. I also obtained my master's degree last year at Hunter College and did my second internship at the Bridge within the Aging Services team. Prior to obtaining my master's degree, I worked in the foster care system within the group setting of ages 13 to 22. And I also worked within the Harlem population providing mental health services, specifically within the Latinx community. I'm going to be passing it to my colleague.
Hello, my name is Alisha Petteway. I'm the residential manager at Peter Beischman House, better known as PBH. I've been with the Bridge for 6 years. I started out as a per diem, then I worked my way up to residence counselor, community resource specialist. I also was assistant manager. Now I'm the manager of the residence. I worked in different types of housing, supported housing. That's all. I'm sorry. I forgot that quick.
Good. Okay, so I just wanted to kick off with this quote. It says, "There's an inherent risk in most everything we do in our lives. This should not exclude us from participating, but rather ensure that we properly plan to mitigate harm that can be associated with the various domains and life activities." So I like this quote because I feel like it's a good foundation for talking about risk management. Anytime we go into a program to talk about risk management and what we're doing, we always like to say to our staff, we are not asking you to be mind readers. We are not asking you to be psychics, right? We're not asking you to look 5 years from now and think of every single bad thing that can happen, right? Because that's very anxiety provoking, right? All we can do is plan for what could happen and do our best, because at the end of the day, the people that we're supporting are humans. They're adults. They're allowed to make decisions whether we agree with it or not. So I like this quote, and I just feel like it sets a good foundation. A little bit of background about the Bridge. So we have a bunch of different programs. We have outpatient, we have mental health clinic, PROS, Ticket to Work, ACT, SOS. We'll soon have an IMT team. We have various levels of housing. So we have permanent housing, we have supportive housing. We also have safe havens, one we're about to open. And I feel like every year we're building new programs. So we're constantly expanding, as I'm sure is the same at the Jewish Board. And then we also have, down at the bottom, you'll see special initiatives. So our program is considered a special initiative within our residential department. We do have 3 specialized programs to target complex needs that tenants may face. And our program is one of those specialized programs. So we call ourselves the Clinical Risk Management Team. I've said for 2 years that this is a working title, and I think at this point it's probably just going to stick because I can't think of any fun acronyms. They're all taken. Everything is taken. So our team used to be very small but mighty, and we are getting bigger and mightier. I have my supervisor is Rebecca, and then myself and Surgein, and we recently just received news that we're going to be hiring for another clinical coordinator and now a harm reduction specialist. So we know things are working because they're asking for more of it. I'm going to let Surgein talk about our services.
Yes, so a little bit about our services. One thing to note about the services that we provide is that they may vary depending on the case. We know that we have complex cases, so we do participate with clients for approximately 3 months. In some cases, it might be longer. In some others, it might be less. But we try to do a kind of rapid turnover because of the amount of clients within the residential program, and there's only the 2 of us. So that's something to note. But one of our services is crisis intervention. Sometimes when there is a crisis in a residential with a resident, we come in and we are able to assess the client. We kind of meet with the client and provide safety planning. But we also have the goal of crisis intervention is to meet with the program and the staff and kind of discuss intervention plans moving forward after an incident. And the goal of the crisis intervention is for all of us to feel safe in the community and also within the program and the staff, which they're very important in the work that we do. Another one is case consultation. So most of the time we are emailed or we are called or stopped by a case manager or program director or higher management, and they're asked, can we have a 30-minute conversation about this specific client, in which we schedule a 30-minute conference. And the goal of this case consultation is to have all providers within the bridge come together, discuss the concerns, and then moving forward, planning, an intervention planning that will take further in the next couple of weeks. We do kind of do follow-ups after case consultation, depending on the intervention plan, but the goal is for all of us to discuss the concerns of a specific client. We also do facilitate conferences with external and internal programs. We know that a lot of our clients have outside providers, and there are sometimes challenges in communication, or we might not be sure of what they are providing to our clients. So the goal of the facilitating the conferences is to kind of come together with the solution of the concerns. All of this is with the consent of the client. Obviously, if the client does not agree that we speak with outside providers, we do not do so. We also do complex discharge planning, and they might look differently. However, the goal of the discharge planning is that we know a lot of our clients are having many hospitalizations, and the goal is to reduce those future hospitalizations and kind of stabilize them for them to thrive in the community. So, for example, if a client is being taken to psych, we are coming to the hospital, meeting with the social workers, meeting with the doctors, and providing collateral information. We're also kind of providing referrals or asking them to kind of complete some certain referrals that we will continue to follow up once the client is discharged. In other cases, we might also be advocating for a client based on our assessments that might need a higher level of care for a nursing home referral, or for them to be placed in a higher level of care due to the safety concerns that may be presented. Now, high-risk referrals, they include AOT, ACT, IMT, SOS, pathways. So a lot of the intervention plans that we discuss in case consultations will include a certain type of referrals that Lexa or myself will be completing. Most of our work is background work, so we're not meeting with all of our clients that we have in our radar. We are mostly doing the documentation or referrals. And lastly is high-risk training. So we have been able to provide certain trainings to our programs, and specifically the residential staff and case managers. One of them has been person-centered documentation, safety in the community, especially for those case managers who are visiting clients in scatter sites. We have also been able to provide Narcan and fentanyl test strips to clients and also the staff. And lastly, which we'll be talking about more, it is the high-risk meeting, which we'll be talking more in this conference. Yes.
I just want to add, too, I think the benefit to having a specialized role within your agency that focuses on particularly like these services that we provide is that you have somebody in your program, especially residential, right, can feel a little disjointed because you have one building in the Bronx, you have one in Brooklyn, one in Manhattan, right? Geographically, it's everywhere. So it can be hard to get everybody in one space and say, hey, this is how you become an expert at doing an ACT referral. Hey, this is how you become an expert at speaking with Kings County about how to get an AOT order in place. Hey, this is how we become an expert in this, right? So it's so difficult, I think, in residential particularly to really train the staff, get everybody in one room, and then continue those conversations. So I feel like it's a benefit to our program because Surgein and our focus is these services, right? We can find all the little ins and outs, what to say, what not to say. If we get told no, we know how to go around it, right? So having one or two people in your agency that really knows it in and out is extremely beneficial. I mean, I know especially in residential and during COVID, right, the turnover of case management and residential counselors, right? And thinking about having to retrain somebody every 3 months on how to do an ACT referral, I don't know that I could handle that as a supervisor, right? So I think the benefit is that, yeah, we can specialize in all of these services, and we can train our staff when it's appropriate on how to continue these things when we're not there or if we can't do it. But I just wanted to throw in that that's the benefit to having a specialized role like this within your agency.
Now we're going to be talking about the risk categories. I know we mentioned risk many times for the last 10 minutes, but our focuses of risk is within the suicide, violence, and medical risk of our clients. So how they might look like, we are looking at the protective factors for suicide. We're looking at the history. We're looking at their changes within their behavior and their functioning in the program. And we are also looking at significant changes such as a loss of employment or a loss of a parent or a family member. And all of this information is coming from the staff that's in the program. And based on all of the assessment, then we can proceed and say, okay, this person is high risk for violence. For suicide. As for violence, it's very similar. We are also looking at the history of violence, not just for someone who might be a victim of violence, but also someone who might be the aggressor of violence. And we're looking at the history, the current presentation, their functioning, their daily interactions with staff and community members. And we're also looking at significant changes within this last six months or so. Based on that assessment, then we can say this person is high risk for violence. And lastly, medical. Medical is also it can be a little challenging sometimes to determine because a lot of our clients have medical diagnoses such as diabetes or so-and-so, but we are looking at if there are big gaps within their medical providers, if they haven't met with a medical provider for the last 2-3 years and they have diabetes, and we have observed that they have gait mobility issues, and we are trying to provide them with education and connections to the medical providers. It is kind of very similar looking at protective factors, their changes within their functioning. And lastly, in this slide, we can see that in medical, we also have overdose risk. So as we know, the overdose is affecting all of our communities, but when one of our clients experience an overdose, we are able to come in and meet with the client sometimes on one-on-one and provide them with Narcan, fentanyl test strips, training. We also can provide them with resources such as the Overdose Prevention Center located in Washington Heights or in Harlem. We kind of provide them with the tools for them to use safely, to choose their what they want to experience safely in the community.
Okay, so now that you know a little bit about what our day-to-day looks like, I just kind of wanted to go into how we implemented this program, because it was a pretty big undertaking. So whenever I started the role in 2021, all we really had was a policy. It was like a 5-page paper of what we thought this may look like. But what I really appreciate at the Bridge, and I think it's really important if you're wanting to start a program like this or integrate risk management, is that our senior management recognized that we needed a bottom-up approach with this kind of program, right? If we're putting a program in because we want our staff to feel safer, to feel more supported, then we need to hear directly from our staff what's going on in our program. So again, the benefit of having like a specialized role is that senior management, they have so much going on. I'm sure it's hard to go into every single program and understand the unique needs that everyone may have to a degree to build this kind of program. And so when I came in, I came in from an ACT team where you're running 24/7, boots on the ground, right? Like you never ever stop. And my supervisor had to like put the brakes on me because she really had to tell me how important it was that this is a slow rollout and it's a very intentional rollout. So really like that first spring and summer, I just spent those first few months doing a ton of readings, which I'm going to get into in a future slide. I spent a lot of times just sitting at the programs, watching incidents happen, getting involved a little bit, but I honestly was just there to see like how staff were already managing, what was going on in the programs. They were doing a lot of things right, and then there were some things that we could improve on. So how can I build on the strengths that these programs already have, rather than focusing on everything bad that could be happening, right? And then transitioning into the fall, it's when we're really like observing case conferences, right? How do our programs work with ACT teams? How do they work with hospital discharge planning? How are they working with external providers, and do they need more support with this? And we found out that they do need a lot of support in understanding all these external programs. Thanks. And so we also, working with other departments is a big thing, right? So having one person who can kind of help synthesize risk, not only within residential, but like agency-wide, right? Because this is really a culture change. We're shifting our culture to not only more safety, but more person-centered, more trauma-informed, right? So not only am I understanding like what does residential need, but what does outpatient need from us to be good partners, right? Especially when we have mutual clients that are high risk. Understanding who do we go to in outpatient whenever we have issues? Who can they come to me whenever they have issues? It's also working with departments like intake, right? How can we make sure that risk management is infused from the beginning, which is the intake process, and then we work with our awards department, right? So figuring out what data can we start pulling, what data do we already have. A big thing for us, and I had a great supervisor who had already built a program, so she had a lot of understanding of what we needed, but we knew that, so we started this when we were kind of still in the COVID pandemic, right? And things are so chaotic, so I can't ask staff to do more than they're already doing, right? They're doing the best they can with such limited resources, so we can't come in and add a bunch of assessments and a bunch of screenings, right? So just really understanding everything going on, and figuring out how do we build on things that staff are already doing so it doesn't feel like they're having to do more. And then, some of the data that we looked at were incident reports, hospitalization data. We got into psyches. If people aren't using psyches, it could be a great resource. And with that data, we were able to say, okay, out of our almost 30 programs, these 10 programs are on paper experiencing the most incidents, so let's go in and see like what's going on. And through that process, we learned scattered site is actually having just as many incidents, but because their incident reporting requirements are different, we're missing stuff, right? So it's really focusing in on your data that you already have, and not necessarily making new ways of doing things, but really just building into already started processes. And then it really took us a full year for us. The slide that Surgein went over, our services provided, it took us a year to be able to say this is what we do and say we can confidently do this for our program. So that was a year of relationship building with programs, understanding the needs, and then being able to say like this is actually what they need. Because originally when this program was created, we thought, oh, it's really just going to be me, and I'm going to just consult, and I'm never going to see a tenant. And then when I started that role, I thought, there's no way I can do this and not see a tenant. I mean, I am driven to be client-facing naturally, but it also just felt like that's what the programs needed. So that's what we did. We were really kind of able to lead with what they told us they needed, which was nice. And now we're at a point where we're really starting to get into metrics and thinking about assessments that our team can do. So it's been 2 years now, and we're just now getting to a place where we feel like we can pick out metrics that we want to follow. And that's because all of this has been slow and intentional for a reason. And my supervisor has had to tell me many times that that's okay. I think in our field, we're it's promoted to be data-driven, and we really should be, right? But we didn't know enough, and now that we do, that's from that bottom-up approach of figuring out what's going on. So, because the data isn't always going to accurately reflect what's going on in your programs. So once you figure out what it is that you're not seeing, then you can figure out how to match up your data to what's happening in your program. So that's kind of where we're at now. We're expanding our team, which is really exciting. Surgein and I are starting a learning collaborative where every 3 months we focus on a different topic that helps us build our clinical skills for when we're working with tenants and providing advice to residential staff. But that's kind of what implementation has looked like for the last 2 years, and I think it's always going to be called implementation timeline. I don't think we're ever going to get to a point where it's a finalized program, because my hope is that with things like the learning collaborative, with being the people in the agency that can source out new and upcoming evidence-based information and things like that, like we should be evolving every year, right, with the research, and we should be getting better. So we're always going to be changing a little bit, I think. But that's just, we really pride ourselves on flexibility. So that's another thing, right? You have to be very flexible to start this kind of program. But that's also what we enjoy about the program. So I'm going to go to the next slide. Oh, sorry, I skipped that one. And now this is core competencies and training. So when I talked about that first summer that I worked with the agency, I just spent that summer reading a lot. And coming from field-based work, that was really hard to just sit there and read through stuff, right? Because we don't really get that time. So that, like I said, that's a benefit of this specialized role. You have somebody who can read through all this evidence-based information and then talk about it with everybody else. So some of the things that I felt were really important to have a understanding of before we can start doing risk management are these trainings. And if you want more specifics on each training, at the end of this PowerPoint, I'm going to have my email. You can feel free to email me because I do have a detailed document about this. I just couldn't fit it up on the screen. But I highly recommend reading A Pocket Guide to Risk Assessment and Management in Mental Health by Chris Hart. That was a recommendation of somebody from senior management. I still read it once a year just because every year that I read it, I have a different perspective on what I'm reading. We also, I did the Collaborative Assessment and Management of Suicidality, also known as CAMS. So I was able to get trained in that suicide-specific intervention. I highly recommend it because I feel like even if you aren't going to sit down with every tenant and do a CAMS intervention, even the training is so person-centered and trauma-informed. I just felt like it really spoke to our program and fit our program well. So I do recommend that. We do a ton of trainings through the CPI learning community. I think it's CPI that has the suicide-specific modules within the trainings that are really, really great. And like I said, I have all the names for these if you want to email me later. CUCS has great trainings. Right now I'm watching the one, the violence modules to help inform our programs. The Coalition has great trainings. I'm sure we've all done a lot of these. And then SMI Advisor, they have great trainings. And then specifically over suicide-specific interventions, SMI Advisor is great. And they also, I think on SMI Advisor, you'd have to go to the website, but they used to have a hotline that you could call and talk about challenging cases with. So that's a resource if anybody needs it. As Surgein kind of mentioned, we also thought it was really important to focus on person-centered documentation, right? We're talking about people who have extensive trauma histories, who present with really challenging behaviors, and we want our documentation to reflect what we're seeing without that kind of judgmental stigma that can come from when you're reading it, right? And that's kind of twofold. We do that to make sure we're being person-centered, but also all of our residential staff will go in and read our notes, and we hope that that serves as a model to how we're talking about our tenants. We think trauma-informed care, I'm sure most agencies are doing trauma-informed care at this point, but we specifically read more about that outside of our trainings that we're required to go to for the agency. Dignity of risk and duty to care. So that's that was popularized, or it began with the disability rights movement, and then I believe it's Pat Deegan that has really great information. I always forget what her program is called, but dignity of risk and duty to care. At her training, I think that's where I got that quote from at the beginning of the presentation. But the reason that we focus on dignity of risk and duty to care is because when we're advocating for services, right, we want wraparound services for our clients, but we also understand when we're advocating for certain things like AOT, right, court-mandated services, that's traumatizing, right? We only want to do that when we absolutely have to, when there's a huge safety risk. So we need to continually kind of check ourselves to make sure we're not being over-involved or under-involved. So dignity of risk and duty of care is really important to our foundational understanding of risk management. Harm reduction, of course, right? That's kind of our driving philosophy in any of the risk factors, is that we're working within a harm reduction model. We also, we compiled a document about all of the high-risk related referrals and systems that we work with, so that when we're talking about it with staff, they can continually read up on it when we're not there, or they can refer to it if they're not able to reach us. And then we also obviously want to know a lot about supportive housing, because risk doesn't just live in a vacuum, and risk is different in every single setting, right? The risks that we see in this room today are going to be a lot different than the risk that we see when we step out of this building, and risk is going to be different on an ACT team than it is in a residential setting. And even within residential settings, right, going back to how I talked about the incident reporting, risk looks a lot different in scattered site than it does in a supportive housing congregate setting. So understanding supportive housing and all the different models is important to help you understand what the staff are doing and how they're managing risk, because every program is going to look different based on how they're staffed. And I'll let Alisha take over from here. So Alisha, whenever she started her current residence at PBH, we knew we wanted to work with her, and we wanted to start the high-risk meeting in her program. So we've been doing high-risk meetings now for a year. Almost 2 years, yeah. So we've worked pretty closely together now, and I'm going to let her take it away.
Yeah, please excuse me. I'm having an allergy attack right Understanding risk management and development appropriate interventions. Additional clinical supervision support with complex cases. Prior to starting high-risk meetings at PBH, it was kind of difficult to understand where the clients was coming from. Once the meetings started and I was able to know like violence, suicide, and medical, and putting it all together, now it kind of gives me like a better idea and sense of what to look out for with my clients. The high-risk meetings just really helped me a lot understand that part.
Yeah, I love the high-risk meetings with Alisha because it'll be like, oh, have you noticed this symptom? And she's like, oh my gosh, yes, that's how you say, yes, that's exactly what you call it. So she's just so expressive in the meetings. It's a really fun meeting. I wish you could all be a part of it.
Thank you, Lexa. Who should join the meetings? Everyone, like residents, counselors, the CRM team, management, senior management. I also believe like to get the information out to my staff because we have overnight staff and it's hard for them to know what's going on in the residence because they are the overnight staff. So it's important to like introduce it in the shift summaries or send out an email making sure everyone has the information. I guarantee you walk in my building and ask who's on high risk. Overnight should be able to tell you. Maybe maintenance could probably even tell you, but everyone should know. This way everyone is aware and not caught off guard of what's going on. These meetings usually last like an hour and a half. When we first started, they was like 2 hours, maybe even 3, because we didn't understand what was going on. So when she said, you have anybody medical, and like, oh, we go through each client, and it's like, well, yeah, this one, she went this way and hit somebody in the street, and it's like, well, that's not really how we determine if that is high risk or not. So once I learned how to separate once I learned how to separate medical and suicide and violence, it's much more easier. And our meetings is like 30 minutes now. Yes. And definitely monthly. I think monthly is beneficial just to keep them going, to not stop. This way we all knows what's going on. Like knowing your clients or knowing the people that's in your residence, this definitely helps.
Thank you, Alisha.
You're welcome.
Yeah, so I would say this is how we format our high-risk meetings in almost all of our buildings. So to be honest, we don't have our high-risk meetings in all 7 of our programs, and that's because we're going in slowly and intentionally into every program to figure it out, right? So Alicia's building has
24 clients.
24, yeah.
Sorry. When we started, we maybe had 12 to 15 of the 24 on high risk. Now we're down to 3, I believe. Yeah. So for her, like we really can get through a meeting in 30 minutes, right? But I'm sure there's people out here with scatter site programs. One program may have 150 people. So how do you get through 150 people in an hour and a half? I'm not sure yet because we're still trying to figure that out. So that's where flexibility is key, right? But so this may look a little bit different in every program that you go into because every program is different and unique. So now we're going to talk about risk severity, right? So we've talked about the risk categories we focus on, which is suicide, violence, and medical. And now we focus on how severe is this risk. So within our meetings, we only focus on people that we would consider high risk. And that's because if they're imminent risk, which the definition of that is immediate danger to health, property, or in the environment, we probably shouldn't be sitting closed off in a meeting room if there's a crisis happening outside the door, right? We should be calling 911 immediately. So that's why we're not going to talk about imminent risk in a high-risk meeting because we would be doing something, right? So we're only focusing on high risk because we're spending this hour and a half to focus on the tenants with the most complex needs within these risk categories.
and then the interventions that we can complete after. So if a crisis is happening, we need to be acting now. We don't need to be planning. So let's say in Alisha's program, the 20-something tenants we have, what we do is we just run down that list initially, and we mark off everybody who we know within those 3 categories we'll never talk about for that month. And then with maybe the 5 or 6 people that are left between that may be moderate or high risk, we talk about, well, I'll go into another slide, but we talk about certain things that help us determine if they are moderate risk or if they're high risk. So I wasn't able to fit it up on the slides, but I do have like what we call a high-risk cheat sheet of things that we should be touching on when we talk about every tenant, and that helps us standardize what we're doing a little bit without having the assessments in place yet. And yeah, if they're low risk, like I said, we just don't talk about them because this is our time to just focus on people that are high risk. So this slide is about what's important to talk about, right? So there's so much that we could talk about, but the great thing about residential staff is that they see everything, they hear everything, right? Most programs are there 24/7, and even when they're not, they have such rapport with their clients. I don't know how they find out everything, but they do, and that's why Alisha was saying that everybody that's involved in that program needs to come to the meetings because the information is so valuable of what they're observing, right? Our staff may not be social workers. They may not have a master's degree, but they are expert observers, and that's something that we couldn't ask for more for, right? We just need to know what's happening. So things that we talk about. So we talk about. Also, I forgot the exact name of this. If you want I adapted this. I don't even know what you would call it. This picture. Because I formatted the words to words that we use in our agency, but I know the PowerPoint will be posted, and I do have at the bottom where I pulled this graphic from. I just can't read it. But so, yeah, we talk about clinical data, right? So enduring factors, so things that are not likely to change over time. We talk about, sorry, I'm just going to get your right here. Oh, here it is. So we talk about protective factors, strengths, high-risk history. We talk about current presentation. How are they engaging with their current supports? Not just ACT team, but how are they engaging with their family? How are they engaging with that boyfriend that's in and out of jail? How do they act whenever he can't come visit you at the residence, right? We talk about triggers or immediate stressors. We also talk about risk status. So that's kind of like your risk relative to a population, right? So I think I said it already. Risk in residential is going to look a lot different than risk on an inpatient unit. Or risk in scattered site is going to look a lot different than risk in a congregate setting. We're also going to talk about risk state, which is your risk relative to your baseline, right? So going back to this slide, right, we talk about people having multiple risk factors, few protective factors, or stable risk factors, many protective factors. So what's their baseline with their risk and protective factors? And then also, what are foreseeable changes? What are things that could change some of these more dynamic factors, and how could that impact our risk assessment? And available resources. So what do they have on hand that can help them cope? And not only that, but what's going to add to our treatment planning? So these are all things we talk about. I do actually, like I said, I think I mentioned this on the last slide, but I have this broken down into bullet points, exactly what we would be talking about. So if you want that information, my email is at the end, and you can email me and ask for it. And now, okay, so we have determined what risk category they are: suicide, violence, medical. We have determined the severity, whether it's moderate, high, low. And now, like, what do we do, right? So we've determined that somebody is high risk. What should we be doing? So this is more just general. I'm actually creating a document right now that is more detailed about each risk category and general recommendations that we would have. So like I said, if it's imminent risk, you should be doing something immediately, right? Because that means a crisis is happening and 911 probably needs to be called. But then if it's high risk, that's a little bit different. So if it's high risk, what we would say is increase collaboration, so that whether that be with providers or family members or friends, given that we have consent, that's increasing our contact with the tenant, right? So maybe the program standards is that you meet with the client once a week, but this client is high risk, so can we check in, just knock on their door once a day and say, hey, how are you doing? And some other things that we've implemented is we, I don't know if people in here use awards, but that's our charting system. And so what we use is, it's called the client alert feature in awards. So anytime we put somebody on our high risk list, we add a little client alert that says high risk and their risk category. And that's so anytime somebody is putting in a progress note for this person, they're going to see the flag. And that's going to remind them that this person is on the high risk list. We need to remember the interventions, and we need to keep this in mind when working with the tenant. And we also document. So anytime somebody is high risk, and we've talked about them in the meeting, and we've put them on our high risk list, we all the things that were on the last slide that we talk about, that goes into a note. And that's just so, like Alisha was saying, right, there's night shift that may not be there during the meeting. That's so whoever can't be there at that time can always refer to the notes, so they know. They not only know the intervention we discussed, but they know like what we talked about to get them on that list. And then really for moderate and low risk, it's just observe for changes. So that's what we recommend really in all the risk categories, but a lot of times we may have people that end up on our being medium risk, and it's kind of like there's concerns here. It's not too severe to be high risk, so all we can really do right now is observe for changes. And now we're going to talk about a few case studies. So in all of these case studies, it's just different examples of how we got involved in a different case and the outcome. Certainly, there's been a few where we weren't able to have a successful outcome, but most of the time we're able to make a lot of movement because this is what we spend all of our time doing. So, we do have, I don't think we included this in any earlier slides, but we do have a very limited caseload. Like, I don't do as much client-facing work now, but Surgein, we really try not to let her work with more than 15 people at a time. And that's because one day she may need to spend 4 hours with somebody, talking to them, right, and figuring out what they need. Or we have a free day on Friday, but I guarantee you Friday morning we're getting a call, hey, somebody's hospitalized, can you run over to the hospital, right? So we keep a small caseload so we can spend a lot of time on one person, but also because you need flexibility to really be able to have 2 or 3 hours, or if you need to run to a hospital, you need to run to a program. But yeah, so I'm going to let Alisha and Surgein kind of talk through some of these cases that we've worked with.
Thank you, Lexa. So for our cases, we're going to be, due to confidentiality, we're going to be changing their names. So for case number 1, we're going to call this person Maria. Maria is a Hispanic female in her early 40s. She's diagnosed with schizophrenia. And the reason she was referred to our team was due to high-risk violence. So she was presenting, kind of making threats to the neighbors. She was cornering the neighbors. She was not allowing neighbors to come in or out of her building. The reason of this, it was due to her psych symptoms. So they were showing up, and her her daily function was being affected due to her diagnosis. So she was having a lot of ER visits, but after 24 hours, she was being discharged. By the time that we were notified that she was being at the hospital, it was too late for us to advocate. So in one of her last hospitalizations, we were able to her date of discharge, we were able to follow up with the social worker. The social worker provided us with a follow-up appointment. We went with her to the appointment, but this is a person that she cannot sit for more than 30 minutes to do therapy or to sit with someone. So the moment that at the follow-up appointment, they told her, you need to do therapy once a week and come in and see your therapist once a week, she walked out. And at that moment, I was like, okay, so what are we going to do next? So we kind of continued managing with her. We were providing her psychoeducation on her diagnosis. So she will inform us that she was having spirits. This is what she calls them hallucinations, auditory and visual. So the spirits are very triggering. And we were able to come into her house. She was living in an independent housing at that moment. And due to the assessments that we were observing, she was leaving water running and the gas running for many hours. So due to the safety concerns, we were able to hospitalize her. I know that we don't want our clients to be hospitalized, but due to the safety concerns, we needed to advocate for admission. Once she was admitted at the hospital, we were connected with the social worker at the hospital and the doctors. We provided collateral information, and we were also advocating for an AOT order. Once that was provided, I completed AOT, referral care coordination referrals. We also worked with the intake and property management and higher management, and we discussed of her being moved, with her consent, moved from an independent setting to a more supportive setting. And right now, this client hasn't had a hospitalization since the beginning of the year. She is connected with providers. She is also meeting with family members. She actually calls me probably every 2 weeks saying, I have my appointment on this date. And probably in the beginning of the year, she couldn't remember, she couldn't articulate her needs, and now she's kind of meeting with her case manager on a weekly basis. She is thriving right now in the community. And we're not saying that there's not going to be any more hospitalizations or that there are no other risks that's going to happen in the future. But for the moment, this client is pretty well connected, and she's at baseline at the moment.
I also just want to add, I think the reason we do like our foundational concepts, that like person-centered documentation training, I think this is where we can see that it's really infused in everything we do, right? So when we met with Maria, Surgein wasn't saying, take your injection because you have hallucinations, right? Mm-hmm. That's not how she understood her symptoms, right? She understood them as saying, these are spirits I see and I hear. And when I run the water, I don't hear them as much. And when I play my music really loudly, they're nicer to me. And when I run the gas on the oven unattended, it's safer for me because now the spirits aren't attacking me. And so Surgein was able to go in and say, now that you've had your injection, are the spirits' voices a little quieter? Are they as mean to you? What are they saying to you? So it really shifts it from talking about symptoms, right? And I'm sure that this is what happens in outpatient clinics, and I'm sure therapists there are able to do the same kind of work we are, but she just couldn't make it to a clinic initially, right? So for us to be able to provide that person-centered psychoeducation was really important. And yeah, I just wanted to add that because Surgein did such a good job with doing that. She's actually we had her on the ACT wait list, and she's doing so well with her outpatient clinic. We're taking her off of the wait list. So she's really, really thriving. Yeah.
For case number 2, we're going to call this client Joe. Joe is a white male in his late 70s. He's diagnosed with... He's diagnosed with schizophrenia, intellectual disability, and congestive heart failure. This person was living also in an independent apartment in the Bronx. There were some medical concerns with Joe. He was found several times unconscious by community members due to his medical diagnosis. He was not connected to medical providers or mental health providers. He was not engaging very well with case managers or other providers, so there were some assessments that we were able to come in, and once we met with him, it was kind of obvious that his daily functioning was poor at the moment. He didn't have no home health aid, and we were able to kind of work again with intake department and work with the property management department and look for a higher level of care for him within the community, because we knew that once he was provided with connected to the providers that he needed, that he will be able to thrive better in the community. So this is a client that was recently moved to Alisha's program, and she can tell you more about his current presentation.
Joe moved into PBH in December. When he first moved in, he wasn't mobile. He wasn't talking. He couldn't talk to people. He did not express himself very well. His sugar levels was always 500. He had problems with balancing himself, could barely stay standing. Now Joe is very vocal. We almost get cursed daily. His sugar has been regulated. When he do his levels, is more like in the 1s and the 200s. I mean, it's still kind of high, but it's not where it was at before. He's limited. He does not fall as often anymore. We was able to help him get a walker. We was able to help him get other things. Joe is actually doing very well. It's something else I wanted to say about Joe. I can't think of it right now.
Joe is nicknamed our security guard because he likes talking to our staff so much. He doesn't leave the front desk. Yeah. And this is a guy, I'm not kidding.
On the door.
Yeah. Surgein and I thought when we started working with him in his old apartment that he couldn't speak. We thought that there was either a medical or a clinical reason why he wasn't talking. And it was really just a change in environment and the right supports, and he is thriving. He has a home health aide now, too.
He has a home health aide. He goes to his doctor appointments regularly. He has psych appointments. He takes his medication on time every day. If he's not downstairs by 9 o'clock, we're worried. Because usually he's down like 8, 7 o'clock. So Joe is really definitely doing very well.
Yeah, when we started working with him in his old apartment, he also had no benefits because it's not something he could manage independently, and he wasn't connected to the right services to help him, right? Because in scattered site setting, which is what he was in, it's 1 visit, maybe 2 visits a month, and that just wasn't enough to support his needs. I mean, Surgein and I, the first day that we walked in, we ran out after 2 minutes because we looked to our left, and the kitchen wall was so covered in roaches that you couldn't see the wall. So the severity, the how he was living, it wasn't his fault, right? It was just that we needed to provide him the right supports, and the complexity of his case was so much more than a case manager in scattered site not only can handle, but their job duties, right? That's far outside the scope of what they should be managing. So we were really able to come in, and we were helping I think we were doing daily apartment checks with him in scattered site. So that was a really, really successful case.
He's also on money management, so
he's on money management, yeah.
Okay, so our case number 3, we're going to name this person Bob. Bob is a Hispanic male. He is in his late 50s. He was referred to us, he's diagnosed with schizoaffective and PTSD. He was referred to our team due to, at the moment, medical. Bob was having overdoses probably 3 times a day within a span of 1 or 2 weeks. So I was able to meet with him kind of weekly, provide him with resources, harm reduction tools. And sometimes it would be an hour long, and he would just sit there and kind of talk to me. And I would listen. And from there, he was like, I would like to be connected with this, and I would like to do this. At one point, he's like, can I be referred to ACT services? And I'm like, no, you're not qualified for ACT services, but I can connect you with other services. So I continued to work with him for approximately less than a month, and then in our high-risk meeting, Alisha mentioned there were some concerns of suicide. So once there were some concern of suicide, and he does have a history of attempt, I was able to continue to meet with him and work with developing a safety plan. also connected him with therapy and psych. And I would say that has been since then, there hasn't been an overdose risk as it was a few months ago. So I'm not saying that the risk of overdose is never again going to happen, but he has been he's more stable at the moment. And he's also living at Alisha's program, and she can tell you more about Bob.
Bob, he still seems to struggle some. Like he still seems to struggle some, but we don't have the overdoses as much as we did. At one time, it was like 4 days straight. That's no longer happening. There haven't been an overdose for him in, I want to say, 6 months, or could have been longer, than 6 months. He's going to the new program. He now has a psych doctor. He's becoming more connected with his family, which was one of the biggest problems on why he felt the suicide ideations. He speaks more with a lot of the people in the residents. I don't know. That's all I can say about Bob.
Yeah, I think this is an interesting case too, because it highlights at different levels how you can intervene, right? So originally, before we started working with him, and all these overdoses were happening, we had just put in Narcan community boxes in all of our residences. And then our next step after that is we were going to start training all of our tenants. So even though he was experiencing those overdoses at that time in the residence, because all of our tenants in that building and his friends were trained to spot what an overdose was, they would run to us and say, hey, you need to go get Narcan for, Bob, sorry. We need to get Narcan for Bob, and you need to go resuscitate him. And that's what was happening, right? Because without those tenants telling us, that would have been another fatal overdose, right? So that first step of us being able to say, hey, we need Narcan boxes in our building, and then saying, oh, hey, we need to train all of our tenants. And then the next step being, okay, now let's meet with him directly. Okay, now let's do Narcan training again for him 2 times. Let's train him in fentanyl test strips multiple times. Let's keep coming back and talking to him about it. So that's at multiple levels in his intervention, we were seeing changes. So I think that kind of speaks to, if you were to have this role in your organization and you can't do as intense direct work, even those small changes you make with putting in a Narcan box in your building, because that's what we were able to see was needed, it helps, right? Our goal, the goal is that overdoses never happen, but realistically with substance use, they are going to happen, and they're going to keep on happening, right? So at multiple levels, you can make your program safer within any risk category with the resources you have available. Is that all the case?
No. Yeah. So this is kind of before we go to a question and engagement. This is kind of our data from last year. We were able to provide services to 82 tenants, and in that we provided staff support. When I say staff support, it was more of completing psychosocials or completing 2020 applications for certain clients. We also collaborated with outside community members, discharge planning, referrals, and case consultations. For Narcan trainings, like as she said, we have been able to dispense Narcan to all residential programs where clients are able to get Narcan and fentanyl test strips free in all of their entrance in their buildings. And all of our staff, about 77 tenants and 123 visitors and staff are trained for Narcan. And, these are in hopes that the clients are able to use harm reduction tools and stay safe in the community.
I'm sorry.
Yeah.
It made me want to go back to Bob, this section here. So he wasn't always open with substance use. They usually are. So when staff was holding the strips, the clients was very nobody wanted to come to us. Nobody wanted the strips. So because of this team only, I created like a harm reduction section in the community area. So along with the Narcan, the community Narcan kit, there's the fentanyl strips, there's a bowl of condoms, there's other things like to prevent harm. But now that kit has been inside the community room, I'm constantly calling these ladies for fentanyl strips. Like, they are going. So, like, at least they doing that much. They testing their drugs and they doing that much.
Yeah.
Thank you.
Yeah, I think in this building particularly, have there been any on-site overdoses this year?
It has not been this year.
Yeah.
This is wood.
Yeah. Not to say that there won't ever be, but if there is, we're prepared.
Yes.
So I think, just highlighting, the flexibility, really being able to go into your programs and figuring out what they need is such a benefit to have one person even who can specialize in doing all of these things, because had we not gone from this bottom-up approach, I'm pretty sure Narcan boxes was one of my first recommendations because it was so blatantly obvious to me that it's what was needed. At the time, we were having deaths and like fatal overdoses every week. It felt like I was getting an email, somebody has passed away. One is we have people dying, and that's the number one thing that we're trying to prevent. Secondary, we have staff responding to these overdoses, and that's highly traumatizing to have to see that not just once a year, but every day you're responding to an overdose. So really figuring out what people need is such a benefit to your program, and that's why I would really recommend having a role like mine in any of your agencies if it's possible. And I'm happy to meet with people, if you're wanting to start a program like this, or if you already have a program like this, like we're working with Jewish Board to talk about our similar programs, because as we've seen before the COVID pandemic and then particularly after, the behaviors are becoming more challenging. And the great thing about New York City is they are coming out with a ton of resources, but how can we expect 400 staff members every month to know what the new thing is, right? So to have one person who can specialize in these things is really important. Like just yesterday, we sat in an OMH meeting, and they let us know that xylazine test strips are now free on Health Matters website. I didn't know that, right? So I emailed our outpatient department, hey, did you know about this? Oh, no, we didn't know about this. We're spending hundreds, thousands of dollars on these strips, and we can now save money on doing stuff like that. So the specialization is really, really critical, I think, for our programs. And now it's time for questions. Sorry, we have a mic up here, but if you're really loud, I can probably hear you.
I really appreciate you and your team taking this on. It's extremely challenging. Just wanted, while you guys were in the process of getting this started for like consultation purposes, in terms of, do you contact the mobile crisis team for, in terms of training, in terms of how to engage mental health situations? Because the mobile crisis does do a lot of the things overlap in what you do.
Yes.
So I was just wondering.
So I didn't. The thing is because I had worked on an ACT team, I had the access to all those CPI modules, which is what ACT teams are trained for. And ACT is different than mobile crisis, certainly, but they're seeing the same people most likely. So that's why I recommended CPI trainings, and I don't know where mobile crisis does their trainings, but that's actually a good idea. I should do that. So thank you.
Thank you.
What was the last strip you just
Mention.
The xylazine test strips. So those are, some people may have heard it called Trank. So in the last year or two, there's been an increase, not only with fentanyl being mixed into the drug supply, but xylazine, aka Trank. So it's a horse tranquilizer. So it's what's causing the open flesh wounds on people using that specific substance, whether they know they're using it or not. So Health Matters, and you can email. Let me just go ahead and pull up my email. You can email me if you want the link to that. Yeah, but it's Health Matters. I'm sure if you just Google Health Matters xylazine strips, They also give out free fentanyl test strips through that website, and I think Narcan probably too. But yeah, that's what xylazine tranq. It's kind of we use it interchangeably. Yeah.
Okay. Other questions?
Yes. You in the yellow. Yes.
I actually have two questions. One is, what's your funding source for this program? Like, how did you get funding for you all?
They just pull it out of our general operating fund. Yeah. I think, the way the bridge is set up is we don't necessarily have a licensed social worker at every single one of our programs. I know some agencies are like that, but we just pull it from our general operating funds. We have been applying for grants, but yeah, right now it's just general operating. Mm-hmm.
Yeah.
In terms of and this is probably a bigger conversation, I'll read a lot of what you offered, but in terms of balancing person-centered and collaborative risk assessment and considering client self-report, if there isn't that level of awareness around risk that services are presenting, how do you make sure that putting the assessment in the tenant's own words or not, and then also for assessments that are being done by non-trained staff, how can you make sure that
So we right now we're not doing any formal assessments or screenings, and that's really been because we're trying to figure out how to do that in all these different programs, right? I probably skipped over this, but we have about 1,300 tenants, and so to do a screening for each risk category, I mean, we can't do that for 1,300 people, right? But then also because our staff aren't licensed, a lot of these assessments that would work don't, because it needs to be from a licensed staff member. So that's our next step, and I hope if we present here next year, I can tell you what we're doing. As far as how we're talking about people who may not see the risk that we see, we use a lot of words like they don't we try to lean away from insight and talk about more as just the person doesn't agree with this diagnosis, right? The person doesn't see the risk the same way that we see the risk, right? Because risk is all about balancing rewards and consequences. And for them, I don't know how they balance it in their head. It's different than how I did. So we try to use a lot of words about, more about what we're observing. I don't know if that makes sense. Yeah. Mm-hmm.
Yeah. Okay.
Hi, thank you so much first for this presentation. It's one of the best presentations I've gone to at Chinny in my
Thank you. I appreciate that.
for how specific it was and how applicable, I feel like I'm taking away information that I could actually bring back to my organization very concretely. And I also wanted to ask, I have also two questions. One, you mentioned at one point some metrics that you're hoping to begin looking at, and I think you anecdotally reported, staff reporting that they feel safer. I'm just wondering if you could speak a little bit more about, outcomes or impact that you've seen with your program. And then the second question I have is if you could speak a little bit about looking at disparities in both assessing risk, so how risk is assessed for different client populations, biases in risk assessment and biases in response.
Yes.
And how you use that in your work.
Yeah, that's okay. I'm going to do your second question first because it's fresh, and I may have to ask you about your first one. Risk bias, I did read more about that when I was beginning the program, and I haven't refreshed enough about it, but that was actually the reason I didn't want to do a lot of assessments, because it's really assessments matter, right? And we need them, and we need them for the data, and we need to have a structured way of doing things, right? Because truly, if at some point, if you don't have an assessment, right, one problem with that is it's all in my head, right, how I'm assessing people. How is my supervisor going to know how to assess if I'm out of office? How's the program going to know how to assess? So that's why I had written down everything that we just need to be observing for rather than an assessment, because I also knew that a lot of the assessments we would be using people of color are going to be more inclined to rate highly on that. And not even that, like the risk, I think it's the risk your risk relative to the general population, right? Because we work in supportive housing and we house people with histories of hospitalizations, of incarceration, right? They're probably going to rate a 10 out of 10. Most people are going to rate high risk in our programs with the assessments that are out there. And that's why it's just been so hard, and understanding biases. That's what's made me really hesitant to do formalized assessments and screenings. I feel like they're valuable, and I'm not saying they're not. I just need to find the right one. Yeah. And then what was
The
your
other
first
question was about outcomes and impact.
Oh, yes. Okay, so we are continually updating our forms and awards to better capture our outcomes because we aren't using formal assessments. So like this slide that I had, that we were able to pull like everything we were doing, right? So our data is now capturing what we're doing. Now the next step in our very slow and intentional implementation is that, like, we know it's working, but why and how? Like, we know that we're getting good outcomes. We know that when we work with people, this is a made-up number, 98% of the time, their hospitalizations reduce or they're just thriving, right? Good things happen when we get involved, and we know that. It's just we're just really trying to figure out our metrics. So if you want to meet with me and talk about it, I'm happy. Like, I love to network. I want to talk to people about this kind of stuff. Because it's something we need, and I know we need it. But we've only just gotten to a place where we feel confident enough to talk about it. Because we tried, I think it was about a year ago, where we tried to pick assessments, and we were just like, we're not there yet. So, yeah.
Okay,
Mm-hmm.
go.
Hi, I'm Benji. I'm a case manager with Community Access and Supportive Housing. And so one thing that I really recognized was the way you talked about hospitalizations, and you say we're there the next day. I don't know about other programs. I know it can be very hard for the case managers on site to get to the hospital right away, and how quick people get discharged, how little information the doctors, nurses, social workers have, and especially with someone who's going back and forth between that imminent and high-risk category, right? You know there's going to be a crisis coming, right? So what do we do when that happens? What are the interventions in place? So I guess my question is like, did you realize that going the next day was so important, or going as fast as possible, getting someone in the room? Because while someone's hospitalized, now you actually have the time and space to get them connected to the resources that maybe is really hard to get them connected to if they're at home and decompensating.
Yeah, so I actually, that just came from my experience of working in an ACT model. I mean, when I worked with my ACT team, when somebody was hospitalized, we would just try to get there as soon as we can. And I felt like it was so helpful, right? A hospitalization shouldn't be meaningless, because if it is, that means they're going to keep going back, right? So if they're there, we want to make it meaningful. We want to make sure that changes are put in place so that it doesn't have to happen again. Now, we don't always, it's not like standardized for every single person that ends up in the hospital. We just can't make it there for every single one. So it really depends on the severity of what happened to cause the hospitalization and how responsive that CPEP is when we're calling. So like Surgein just worked on a case. Well, do you want to talk about it?
Last week, I was working with a case where after a visit, I had to complete a mobile crisis referral due to some safety concerns. The mobile crisis referral came that same day, but after hours where I was not present. The client was then taken to CPEP. And the next day, the first thing I was doing, we were calling with the case manager, calling CPEP, leaving voicemails. We were being transferred to different numbers that we were not even sure who they were. After probably a whole morning calling, I was like, I'm just going to go to the hospital. So I went to the hospital. It was kind of trying to find someone where I can provide the collateral information and advocate for admission because of the safety concerns. So I met with a social worker at CPEP who was able to provide that information on her at the next shift. There are times that what we do, it does help us with admission, but there are times, like in this a specific case where even if we're completing all of these steps, sometimes the CPEP will say, well, we're not seeing what you're seeing, so we are going to be discharging the client. So sadly, we try to do our best to be connected and provide the collateral information to providers, but sometimes, as we know, hospitals have so many clients coming in and out, and we know the system of hospitals. So we're hoping that if in future hospitalizations we're able to kind of provide more collateral information and connect faster. This kind of like tells me next time that she gets hospitalized, just go straight to the hospital and don't make calls. Yeah.
Right.
Yeah.
And even in that situation, I mean, she ended up being put on a medical unit, which we don't really know why that happened, but it wasn't completely meaningless in that we were able to go to the hospital while she was on the medical unit. And, being in a hospital, not just for our clients, but for us, right, you're very vulnerable. And so when somebody comes to visit you, the rapport that you can build there, just, not even to be there to plan interventions or to make any kind of plan, just to be there to say, like, hey, I want to make sure you're okay. Like, we were worried about you. We didn't see you over the weekend, and we heard you were here. We were able to build rapport with her during that hospitalization that I think is going to be really beneficial following that hospitalization. Yeah.
Okay. So let's take this one last question, and then I think we'll wrap up, please.
Hello, everyone. My name is Gareth Faber. I'm a senior case coordinator at Help USA. My question is basically, y'all talk a lot about biases and things of that nature. I was wondering, is there like a machine that they can make for psychiatry to make diagnoses? Because from my experiences of visiting these like psych wards and these psych units, a lot of people are being misdiagnosed. You know what I mean? Because of biases and things of cultural differences and cultural understanding. And many psychiatrists that I've witnessed too, they're not a lot of African American psychiatrists. They're mostly Caucasian, and I think that understanding cultures of African American descent or Hispanic descent, they're diagnosed with severe mental illnesses like paranoid schizophrenia, bipolar with psychotic features, and they diagnose Caucasians more so with milder diagnoses such as depression, anxiety, mood disorder, unspecified. So I'm wondering, like, when are they going to really, and when you deal as a clinician, like a lot of people, they deal, like a psychiatrist deals with maybe like 100 patients, and they're really just skimming through the information and stuff like that, and they're just putting down stuff probably because they're maliciously putting down things on the paper that's not supposed to go there. Like, they're humans before they're doctors, and they practice medicine. They don't know it. Knowing something and practicing something is two completely different things. It's an educated guess. So I'm wondering, when are they going to design a machine for psychiatry? Because all areas of medicine has a machine. From HIV to diabetes to lupus to cancer, you can measure the accuracy and the correct diagnosis that a person has. Mental health hasn't gotten to that point yet.
Yeah, I mean, oh my God, if we could have a machine for everything, then we could all be at the beach right now. You know what I mean? But for me, I mean, to be honest, when we do our high-risk meetings, I don't ever ask what's their diagnosis. To me, speaking to their symptoms and what we're seeing is more important than me knowing their diagnosis. And that's mainly because what you said, in that these diagnoses are coming from biases. They're coming from stigma, right? They're coming from
But a diagnosis can affect you for the rest of your life.
Right.
You know what I mean? Like a person walking down the street that's schizoaffective, they can never get into an assisted living program. They can never be a cop. They can never be a fireman. It's certain barriers. It's like almost having a felony, like, because of the stigmas that are associated with mental health.
Yeah.
So my thing is that, when is a machine going to be made for psychiatry?
Right. Listen, so I look, you're talking about issues that are so deep in our society that we can't, of course, address it here in this workshop with any real depth. But I do want to say that I think that our role as housing providers who know our residents and are in a position to advocate for our residents in these systems that they and we have to interact in, that's a pivotal role. That's an incredibly important role. And I think part of what this set of presenters has spoken to so eloquently is what a difference that role makes when somebody is in a hospital or in any kind of situation. So I think that there's power there in that role, and from our supportive housing community, and I think we should exercise that power as much as we can. But anyway, thank you for your question, and I think it's time to thank our panel.
Thank you.